Hi, everybody. Welcome to this very early meeting on Friday morning. So in case you're not sure, you're in symptom control and quality of life. I'm Lynn Henry. For those of you who don't know me, I'm a breast medical oncologist at the University of Michigan. And this is Michael Fish, who is at MD Anderson as a general oncologist. Didn't work. Back. Sorry, there's multiple green buttons. These are our disclosures. So we have a fairly packed agenda today. We're going to do just some brief overview of the committee. For those of you who have been here before, you've probably seen a lot of those slides. But then most importantly, we have our keynote speakers today. So we have Dr. Jeffrey Weffel, who's joined us from MD Anderson, as well as Dr. Viavida, who's joined us from Fred Hutch. Then we're going to go through updates on our currently open trials, although one of them finished accrual, so we're very excited. We have some brief updates on trials in development, and then we will be hearing from our patient advocates. So this is just an overview of our committee leadership. Catherine Crew, I'm not sure if she's here yet, is our executive officer. Joe Unger, who I know had to return to Seattle, is leading our stats team, but also includes Ria as well as Celine Jones. We have our wonderful patient advocates, Amy Geschwender. We also have a number of other people who really support our team. We have a VA representative, Yunhee Anna Park. We have our project manager, Mariah Norman, and our protocol coordinator, Justine Trevino. We couldn't do anything without them, so thank you very much. We always also like to just let people know sort of both what our priority topics are, but also just as a general reminder that if you do have any ideas, please bring them forward. We've had a number of people bring ideas forward in the last couple of weeks, which we're not presenting here today because they're still very brand new. But if you're doing symptom management studies or have ideas about specific symptoms and would like to try to explore how to do something with SWOG, either now or in the future, please reach out to us because that's what we're here for. You know, we have done or are doing studies on chemo-induced neuropathy, immunotherapy, endocrine therapy, especially aromatase inhibitor. We're hearing about cancer-related cognitive impairment today, but this is by no means a defined list. We can definitely go outside of these bounds. Methodologically, we've done a lot of prospective cohort studies, which have been very successful and can turn into very large biorepositories, which can, you know, the gift that keep on giving. You know, we can keep getting information from them. We have one about osteonecrosis of the jaw. We have one for chemo-induced neuropathy, and then we have the immunotherapy one that is still accruing. We've done some things with digital health interventions, with behavioral and integrative interventions. And then again, this is not, we're not limited to just these methodologies. We sort of span the gamut. You come to us with ideas, we help you develop them. We get it through clinical trial activation, accrual, data analysis, and then really secondary data analysis. And so we always want to be remembering that we're a very multidisciplinary organization. This is certainly not just oncologists. This is we include people like Dr. Weffel. We include research nurses. We include you know, people who do acupuncture. We want to be very inclusive. We want early stage career investigators to be involved as well. We want community-based investigators to be involved. This is not just for senior academic folks. And we'd like to try to get people engaged. So often in these meetings, more so virtually, but also when we're here in the room, a lot of times people don't say anything. And we really want to hear from you. We want to hear if there's issues, if you hate the idea. We want to hear if you like the idea. We really need your feedback. And then we could not do what we do without Hope Foundation. And so I do want to put in a plug for them. They're having their 30-year anniversary, and they support a lot of our early career and mid-career investigators. They support a lot of our seed grants that turn into clinical trials in SWOG. They support some of the studies once you have the data, looking at secondary data analyses. And so please consider donating if you haven't done so already. And if you have, thank you very much. There's information that's out there about the prior grantees, and you'll hear a bit about it at the plenary session. And then I do want to highlight the upcoming funding opportunities. So there are seed funds, $50,000, and that can really go a long way to help do a study at your institution that you can then try to bring forward to a large multidisciplinary study in SWOG. Those deadlines are twice a year. There's an early career and a mid-career fellowship, which is the Coltman Fellowship and then the Career Engagement Award, respectively, to support people who are actively involved in SWOG. And then there's also the Impact Award program, which is a much bigger grant that can be used either leveraging SWOG samples or data, trying to learn more from the trial, or it can be something that might lead to a trial. So if you have any questions about any of these, please feel free to reach out to us. And now I am going to turn it over to Dr. Fish.
Well, we all face the issue of cognitive complaints as we see. Well, we don't all face cognitive complaints now, do we? But many of our patients face cognitive complaints, and many of us probably do as well. And we're interested, as you saw, in trying to tackle that issue and put together clinical trials that will address this. And so I'm pleased to introduce, after all that, Dr. Jeffrey Weffel from MD Anderson, who's the professor in chief of the section of neuropsychology in the Department of Neuro-Oncology at MD Anderson. Jeff, welcome.
Giant green button.
Okay. All right. Well, thank you all. Thanks for inviting me, Mike and Lynn, to be a part of this session and to present at SWOG. Maybe I thought I would start out this morning just by kind of way of show of hands. Is anybody else in the audience a neuropsychologist, or do I get to claim that all to myself? Okay. Has anyone else, is anybody aware of what a neuropsychologist is? Yeah. All right. Most people. Has anyone sent a patient for a neuropsychological evaluation? Okay. Few. Great. Has anybody conducted cognitive testing on a clinical trial in SWOG or another area? Just a few. Okay. Great. Okay, cool. So this is pretty familiar, I think, to everyone then. I've had a really great opportunity to work in a lot of the different cooperative groups in the US, in SWOG, Alliance, NRG, in the Canadian network group, actually with the ERTC as well, and in some NCORE sites. So this has really been an important aspect of my career, and I'm happy to be here to tell you a little bit about what it is that we've done. And as a result of working in all those cooperative groups, you work with a lot of different people, which is really special and wonderful. And you make a lot of lifelong relationships, like I'm sure you all are appreciating and enjoying as well. These are the research disclosures that I have and the consultant activities. So I think everyone understands the context of cancer, but just to make sure that we kind of frame it here, you know, the estimated new cancer cases worldwide in 2018 were, you know, close to 20 million new cancer cases. And I think there's an interesting demographic or a gender distribution. You look at the most common female cancer, breast cancer, and then you look at its global distribution on this map, and you can see that virtually everywhere in the world they're touched by breast cancer, whereas male cancers do not seem to be commonly represented across all territories in the same way, which I think is just an interesting tidbit. When you look at this escalated curve of showing increasing number of cancer survivors in the U.S. over the decades, we see that in 2020 the incidence was very high, and by 2040 the number of survivors in the U.S. is going to be around 26 million. And at that same time, we estimate that the number of survivors suffering cognitive difficulties is going to be 7 to 13 million individuals. And you can go home and Google how many people have strokes, how many people have learning disabilities, how many people have Alzheimer's disease, and you'll see that this outstrips those numbers by quite a bit. And I think we have historically had a lot less attention in our scientific and clinical communities on this issue. The Livestrong Foundation conducted a survey of 2,300 adult cancer survivors and found that cognitive dysfunction was a very common symptom, but management and likely assessment, right, referrals to neuropsychologists, for example, of this issue is very, very infrequent. So I thought I would take you down a little bit of a broad overview of cognitive changes in cancer patients. And we can start with this concept of chemo brain, or cancer-related cognitive impairment, or cancer-related cognitive dysfunction, or cancer and cancer therapy cognitive changes. Lots of different terms for this. Chemo brain was the one that the patients gave us. They said, I've gone through some treatment, I've noticed things aren't the same. And in this meta-analysis, they compared breast cancer patients who had received chemotherapy to healthy controls that had been followed at same times in these studies. And they found evidence for adverse effects of chemotherapy in breast cancer patients on cognition. And specifically, there seemed to be a preponderance of deficits in areas of attention and concentration, speed of processing, executive functions. You can think of this as our ability to kind of organize and multitask in different ways, learning and memory, and verbal fluency. But it's not just occurring in breast cancer patients. There's evidence in the literature that individuals with colorectal carcinoma, ovarian cancer survivors, testicular cancer survivors, and somewhat of a dose-response relationship, prostate cancer survivors treated with androgen deprivation therapy also demonstrating cognitive abnormalities. And recently, a specific SNP was identified that seemed to really increase risk of those adverse effects. We certainly all know the emerging story about immunotherapies and CAR T-cell therapies and the neurotoxicities that can come along with those treatments. And adult survivors of pediatric cancers, their number one complaint is cognitive difficulties. There's also evidence that these non-CNS directed therapies can have direct adverse impacts on brain structure and function. And that's been measured with voxel-based morphometry, looking at T1 gray matter volumetrics, like you see on the left, where there's diffuse reductions in gray matter density, using measures of white matter integrity, like fractional anisotropy, acquired through diffusion tensor imaging, showing decreased white matter integrity really throughout the brain. There's also been evidence of abnormalities in fMRI, functional MRI task activation, as well as connectivity abnormalities, both structural and functional. And I show a couple of those examples here, where you can see on the far right that the breast cancer twin, in this case, who has an identical twin on the bottom row, was generating far more cognitive effort, far more brain effort, more bold activation on a cognitive task than her sister was. And this was thought to be evidence of increased cognitive load in order to perform about the same as her twin did on a particular cognitive test. And then we've demonstrated that there's abnormalities in functional connectomes as well as structural connectomes after treatment in breast cancer patients. So we have a host of data that says this is a real thing. What are the mechanisms? So these are less well understood, and they're certainly under active investigation in many preclinical labs. They include things like mitochondrial dysfunction and oxidative stress, inflammation, like pro-inflammatory cytokine activity, for example, leading to reduced neurogenesis, alterations in neurotransmitters, ultimately leading to abnormalities in dendrites and axons of neurons and nerves, and impaired myelin production. And there seem to be some chemotherapies that target neurostem cells as well that lead to some of this. And there's a very kind of strong hypothesis around microglial dysregulation as maybe one of the unifying concepts that might also be targetable. And that's part of the reason why we're inducing these brain changes and these cognitive changes. But there's a lot of brain tumor patients as well. Although it's a less common disease, it certainly has profound cognitive consequences. And we think that many of these brain tumors present with a seizure or a headache or some focal event. But really, if you look at the presenting symptoms that brain tumor patients have, as the glioma outcome projects did, you'll see that some of the top symptoms are also these cognitive changes. They tend to be ignored or attributed to other things in life. I'm really busy at work, things are kind of stressful, and we don't immediately think we have a brain tumor, so we don't go running to the emergency room. But when we have that critical neurologic event, of course, that takes us in. But at the same time, we realize that the frequency of cognitive deficits in those patient populations at the time of diagnosis is really quite high. And in primary brain tumor patients like glioblastoma, the nature of the cognitive deficits really track with the epidemiology of where the disease often arises in the brain in adults, that being most frequently in the frontal and temporal lobe. And you can see that we most commonly have deficits in learning and memory and executive function. And you can see also a little less common to have cognitive deficits in meningioma, but when those meningiomas are large and they're compressing the brain, they oftentimes produce cognitive difficulties. And our brain met population also frequently are living with a lot of cognitive deficits. Radiation therapy is a very common therapeutic modality used to treat patients that have brain tumors. And as you see on this time curve, you can see that the neurodegenerative processes that can arise after radiation therapy start very early after treatment, within, some would argue, minutes of treatment, but certainly within the hours, days, weeks, and months that follow treatment. And they include things like vascular endothelial damage, inflammation and microglial dysregulation, oligodendrocyte injury, neuronal damage, and epigenetic aberrations. And there's been some demonstration that not all areas of the brain are equally vulnerable to the adverse effects of radiation therapy. There's some regionally selective dose-dependent atrophy of gray matter and white matter integrity seen in the entorhinal cortex and the hippocampus, areas that are very important for learning and memory, and in white matter pathways, including the fornix and cingulum and corpus callosum. So why should we measure cognitive function in clinical trials? Well, the first reason, maybe the most important reason, is because patients want us to. Right? It's not a matter of whether we as an investigator or a team of clinicians want to do this. Our patients want and need us to do this. A number of years ago, in 2015, I was part of this Jumpstarting Brain Tumor Drug Development Coalition that the NCI, FDA, and other partners put together to try to start talking about what should endpoints be in brain tumor clinical trials. And going into that, they conducted a patient caregiver survey in which they asked individuals, in addition to us working on cures, helping you live longer, what would you most like to see future brain tumor treatments do? And their top priorities, as you can see, include retain brain functioning, maintaining ability to walk and perform basic physical tasks, and reducing pain, including headaches. So again, it's a very clear message that this is important to our cancer patients and our cancer survivors. What are some other reasons? Well, in the clinical trial landscape and in kind of clinical trial language, cognitive outcomes are direct assessments of patient clinical benefit. So if you can demonstrate a difference between two treatment arms on a cognitive endpoint, that is directly related to an FDA approvable endpoint of functioning. And we know that both the disease and the treatment can directly and indirectly impact brain and cognitive function. So monitoring the trade-offs between disease control and toxicity can be very helpful in establishing clinical benefit. We know that cognition is critical for occupational and scholastic success, familial and social well-being, independence, and global quality of life. There's been demonstrations that these cognitive endpoints are associated with other outcomes and endpoints of interest. It's cognitive testing and cognitive function in patients with brain tumors are predictive of survival time. Cognitive decline can occur in advance of imaging evidence of progressive disease. It can be an early biomarker of adverse outcomes. Cognitive declines associated with and precedes declines in activities of daily living, our ability to take care of ourselves, our health-related quality of life, and our functional independence. And it's a critical determinant of quality of life. It also allows us to evaluate survival outcomes in the context of patient-centered outcomes. So while we may have a treatment that extends survival, it may come at great costs to things like quality of life and cognition. And so we'd like to know, what are the cognitive problems prior to treatment? Do different treatment regimens have different impacts on cognitive function over time? Are they the same for all the patients that were in the study and receiving that treatment? And can we offer interventions targeting these signs and symptoms to minimize distress and adverse impact? How do we do this? And how do we do this in clinical trials specifically? Should we use screening tests? So this is data that shows the mini-mental status examination. And this was a particular study that used an agent that in neuroscientific models is designed to induce amnesia in mice. And what we found was when we tested patients, if I can get the pointer back up here again, before and after the injection, and then again before and after the infusion and before and after the infusion, and use the MMSE, we see absolutely no change, no adverse effect of this. But when we use a more rigorous test, the Hopkins Verbal Learning Test, you see that drop in function from before to after every infusion. And fortunately, there was recovery, but it had the well-known effect of creating a memory disorder, and it was no longer pursued. Having used the wrong cognitive test, we might reach the wrong conclusion. Similarly, using screening measures like the Montreal Cognitive Assessment, the MoCA, in patients with low-grade glioma, we can see that when we did formal neuropsychological evaluation, we were able to detect cognitive impairments in the vast majority of those patients, but a fraction of those had abnormalities on the MoCA, and an even smaller number were eliciting neurologic abnormalities on neuroexam. Similarly, this is a insular region glioma patient population in which a surgeon at MD Anderson wanted to understand the impacts of that surgical location, the tumors in that region, and his surgeries. And preoperatively, he did a neurologic exam and he found cognitive abnormalities in about 13% of those patients, whereas our cognitive tests found this to be present in over 70% of the patients. So these are very sensitive probes, sensitive tools. And I know this group and many others are interested in using patient-reported outcomes to try to also monitor and measure cognitive concerns. And one of the challenges here has been that there's oftentimes a very weak correlation between the subjective cognitive concerns and the objective cognitive test. And we're going to talk a little bit more about some of the reasons why that might be seen at the end of the talk. The WHO has proposed a conceptual model, a framework for how we measure these different organ systems and the outputs of these organ systems. And they align the nervous system and cognitive function under this body structure and function rubric. And they argue that these body structures and functions have direct correlations or correspondences to activities and participation, things like how we apply our knowledge. Are we able to take care of ourselves? Are we able to fulfill our obligations in our domestic life? But they also are quick to note this very important variable here, that there are many contextual factors. These are environmental and personal factors, things like the presence of supports in our life, our attitudes, our personality, the roles and demands that we face in everyday life that moderate that relationship between the integrity of your brain and your cognitive abilities and whether or not you're actually keeping up in daily life. And because of that, they say the most important way and their recommended way of monitoring these body structures and functions like cognitive function is to use objective performance-based cognitive tests, not things that require an interpretation. And that they also advocate for conducting testing in the clinic to remove the noise of these environmental contextual factors that reduce a more pure assay of brain and cognitive function. And I think if many of you are in this conversation around PROs and cognitive tests, immediately many of these ideas start resonating and they start also kind of banging up against a common thing that we hear, which is cognitive tests are maybe not sensitive enough. Doing these in the clinic is artificial, and that's the reason why we're not seeing these relationships. So I think if you have those ideas in your head, that's great. Keep them there. We're going to kind of visit some literature that will address some of those thoughts. The FDA similarly then says, if you're going to do clinical trials, we have a whole clinical outcome assessment committee. And if you'd like to get approvals for your medications, for example, there's a number of different ways that you can do that. But ultimately, you need to show that an intervention improves how a patient feels, functions, or survives. And there are 4 types of COA measures that they acknowledge. One is a patient-reported outcome. The other is a clinician-reported outcome. So what does the doctor think is going on with you? The third is an observer-reported outcome. What does your spouse, friend, or someone else think is going on? And the fourth is a performance outcome measure. So the fourth is what they recommend for assessing function as it relates to cognitive function. And performance outcome measures are measurements that are based on standardized tasks actively undertaken by a patient according to a set of instructions. So these are cognitive tests, and they specifically cite the example of an episodic learning and memory task, a word recall test, such as the Hopkins Verbal Learning Test revised. So when we were trying to integrate cognitive endpoints into clinical trials in the cooperative groups, there are a number of considerations that we all sat around the table and talked about. We knew that we wanted to use measures that were reliable, valid, and had established change criterion. We knew that they needed to be standardized, objective, and performance-based. We wanted them to produce quantitative outcomes. We needed them to have normative data so that we knew if the patient's performance was really abnormal compared to a healthy control, or if it was normal or even better than normal. And we thought it was important for them to be clinically interpretable. So rather than using experimental tasks, we wanted to use tests that were typically used in neuropsychological practice. We knew that it was important to consider tests that had psychometrically equivalent alternative forms so we could minimize practice effects that sometimes are present when we do repeated testing. They needed to be sensitive to change and relevant cognitive functions. So we could assess, something abstract that nobody experiences, but we thought maybe we should target those kind of high value cognitive domains that are related to independence and function and are commonly impacted by our anti-cancer therapies. We knew that it would be preferable if they didn't require a lot of equipment. We didn't have to purchase a lot of things in order to carry this out. A lot of machinery, computers, other equipment that we use in our practices. And we wanted to make sure that the administration time was relatively brief so that it could fit within the busy landscape of many of your clinical practices. And it needed to be feasible for patients to complete. And probably, maybe even most importantly, that it didn't require that there was a neuropsychologist on staff at everybody's location, that we could ultimately train people on the team to be able to properly administer these tests, send them back to the central review facility, and obtain data reliably and broadly. And as you can see, as an example, the distribution of NCORE sites, well over 1,000 across the U.S. There's not neuropsychologists at all these sites. We all know that. So we arrived at what we've called the clinical trial battery that measures episodic memory, executive function, and processing speed using the tests that you see on the screen. This battery has been endorsed by the International Cognition Cancer Task Force and the Response Assessment in Neuro-Oncology as being a harmonized way to collect cognitive endpoints across trials, across settings, and really across countries as well. Well, with a graduate student of mine, we also wanted to demonstrate that while using this reduced set, about 30 minutes of cognitive tests, we still were capturing the vast amount of the variance in cognitive impairment in these patient populations. So we have a fairly large data set of cancer patients that we've seen over the years at MD Anderson, and we looked at this in the context of brain tumor patients. And we extracted data from hundreds of these patients, and we had our board certified neuropsychologists again go through these cases again and determine a diagnosis of cognitive impairment, and that was present in over half of the patients. And then we did a ROC analysis, and what you can see here is at the area under the curve of identifying impairment from this 30-minute battery compared to a full neuropsychological assessment was pretty robust, about 90%. The clinical trial battery composite score, which is the average of all these test scores, correlated with this full 2 to 3 hour neuropsychological evaluation and with patients' level of functional independence, as you see in the table on the right. But there was not really a strong association with mood variables. And we think that's an important indicator here. Mood and distress are not what's driving the cognitive impairments in these patient populations. It is the adverse effects of the disease and the treatments that they experience. So when we do this in a clinical trial, and for those of you who do this, you know that this is a review of the training and certification as well. You start with the memory test, you move forward with some of the other tests, but then you have a delay that you have to fill in order to, before you can do the recall portion of the memory test. And in that little gap there, this is where we oftentimes slide in patient-reported outcomes. And this could be measures of quality of life or symptoms or subjective cognitive concerns. In order to, I'll tell you first, the role of the study neuropsychologist is to design the methods, endpoints, analysis, and interpretation of the cognitive outcomes. We also have to work with the test publishing companies to license these tests, to design the case report forms, design the metadata capture forms, the test completion codes, the sociodemographic factors that are typically not captured in clinical trials. And then ultimately really to train certified test administrators at national and international sites, and to do all the central review, scoring, query resolution, and retraining that can be required on these trials. This is the workflow that we follow in order to do this. Individuals obviously need to review the protocol as they're already doing. We've developed training manuals and training videos to help with the training and certification process. There's then post-tests and practice test administrations that the individuals do. Those get submitted for our review. Individuals are either approved and then go on to the study to begin testing patients and submitting for a centralized QA review and ultimately data entry. Or there was a problem in their training and they don't seem to understand it, and they go back through the training pathway, the training loop, until they can be certified. And as we're centrally reviewing over the life of the study, anytime we identify a test administration error or other errors that impact the data, then they go back through the training loop once again. So this provides a kind of living framework for maximizing the data integrity on every trial. So doing all of this, we've trained and certified over 2,500 individuals in the cooperative group networks, and we've centrally reviewed more than 12,000 cognitive test administrations in this space. So this has proven to be very feasible and effective, I think. This is a table that's listing the cooperative group trials that I'm currently leading the cognitive endpoints on within these cooperative group networks. These are all primary brain tumor trials, all using the clinical trial battery, as you can see, and having a variety of patient-reported outcomes, targeting things like quality of life, cognitive concerns specifically. And this is the brain metastasis trials, very similar sort of landscape. And there are trials in other non-CNS indications like RTOG 0534, which was looking at androgen deprivation therapy in prostate cancer patients. So in SWOG, we also have a study open and running right now that has cognitive endpoints on it. This study is led by Chad Rusthoven and Paul Brown, and it is called MAVERICK, which stands for MRI brain surveillance alone versus MRI surveillance in PCI. It's a randomized phase 3 trial in small cell lung cancer. Individuals with small cell lung cancer are randomized to either PCI or just monitoring with MRI. The primary endpoint is a non-inferiority endpoint at this time that looks at overall survival, with the secondary endpoint being cognitive failure-free survival. We received BISQUIC funding to support the cognitive monitoring on this trial, and we do this at 7 different times across the first 2 years of treatment. And we hope to demonstrate a difference between these 2 treatment approaches in cognitive failure-free survival that will help establish a new standard of care for this patient population. And we're using that approach. The PROs in this particular study are a multi-item symptom inventory of the METACE brain tumor, a PROMIS cognitive function scale, so a subjective cognitive concern scale, and a single item LASA quality of life scale. So at present, 365 sites have opened the study. We have 539 trained and certified test administrators. At 222 of those are testing patients at more than one site. 171 patients have been enrolled, 149 of them have completed testing, and again, across the life of this study so far, 3,022 tests have been initiated. If you look at this middle row, this shows completion rates, and you can see that we have very high completion rates, even up to the 2-year mark, which I think is fantastic. And this is, we present this in the context of investigators who work across different cooperative groups, NRG, Alliance, and these completion rates are really remarkable. And I think, congratulations to SWOG and all of you that are helping with this. You guys are doing a great job. The most common reason sites provide for not testing, you can see tabled here: scheduling difficulties, patients are dying, patient illness, patients refusing, just forgetting institutional error. The neurologic disability was too severe in some cases. But 99% of these tests that are coming in are producing analyzable, interpretable, valid data. Sometimes we have to discontinue testing. Usually that's because the patient is becoming frustrated or having a hard time managing that engagement, that experience. There can just be institutional errors where maybe they forgot a portion of the test and they have to go back through that retraining loop. And less commonly, there's incident neurologic disability. So let me provide you with a couple of examples of success stories of integrating these cognitive endpoints into cooperative group clinical trials. So as you remember, these neurodegenerative adverse effects of radiation therapy can be initiated very early. And we know that there's a few things that contribute to cognitive deficits after receiving brain-directed radiation therapy. And one of those is hippocampal exposure. We also know that in general, we've seen adverse cognitive outcomes in patients who receive whole brain radiation therapy. And this led to 2 clinical trials. One was the use of memantine along with whole brain radiation therapy, where we hope that memantine would prophylax the brain against the adverse effects of whole brain radiation therapy. And the other was to try to use radiation technology to carve out the hippocampus and stem cell niche and see if that would also allow us to maintain our cognitive function and our memory longer compared to if you had no hippocampal avoidant whole brain radiation therapy. So RTOG 0614 randomized patients with brain metastases to memantine given before and during whole brain radiation therapy or placebo, and followed patients longitudinally over time with the clinical trial battery, the MMSE as a way to probably put the MMSE to rest and no longer have to use it, the quality of life measure, the functional assessment of cancer therapy with brain module, a cognitive concerns questionnaire, and imaging studies. And what we demonstrated was memantine did in fact delay time to cognitive decline. And this has changed the standard of care in most locations, in many practices, such that now that patients who are receiving whole brain also receive memantine to try to prevent some of those adverse neurotoxicities. But there was no difference in self-reported cognitive function and no difference in quality of life on this study. We also had a biomarker component, and what we identified was that individuals who carry the E4 allele on the apolipoprotein gene were at risk for greater cognitive decline when they received radiation therapy. So this appears that we may be identifying biomarkers of risk, and in the future, maybe we could start directing care through these sort of biomarker identified patients. NRG CC001 was a phase 3 trial where we combined memantine with whole brain radiation therapy with or without hippocampal avoidance to see whether or not hippocampal avoidance would also help reduce cognitive neurotoxicity. So patients with brain metastases were randomized to whole brain with memantine or hippocampal avoidant whole brain with memantine. Primary outcome was time to cognitive failure, and we also looked at overall survival, PFS, toxicity, and some patient-reported outcomes. So in this study, we again demonstrated that hippocampal avoidance prolonged time to cognitive decline. We also found that it was associated with fewer cognitive symptoms over time. So there's a bit of a correspondence between the cognitive concerns that patients were reporting and the objective cognitive tests. And there was no adverse impact of not exposing the hippocampus to radiation on either PFS or OS. So it appears to be an oncologically safe approach to consider. So I think this brings up the question now, particularly with that last study, to test or not to test, right? That is the question in clinical trials. So do we need to do performance-based cognitive testing, or can we just use PROs? And I think some of the arguments for using PROs have been that these outcomes about patient function and patients' feelings should come directly from the patient. And it's easier, shorter to have patients fill out forms and have them take neuropsychological tests. That patients don't like testing. Can't we just ask them these questions? Patients aren't able to do the testing. It's too hard. We don't want to do training or certification or test patients on trials. We're too busy in our clinics already. It's too big of a burden. And don't they just give you the same information anyways? Aren't they redundant? So Bray et al. In 2018 reviewed 101 studies that examined relationships between cognitive tests and cognitive concern inventories, mainly in breast cancer studies. They found that in 70% of the studies, there was no association between the cognitive test and the PRO, and it was only weak when it was found. And in 98% of the studies, there were strong associations between these cognitive concerns, PROs, and mood and fatigue measures. And there was generally weak or no associations between the cognitive tests and the mood and fatigue measures. So you're beginning to see some discrepancies between these two approaches and what else might be contributing to some of the outcomes that we're seeing on these approaches. Goodenquist in 2021 used a multivariable regression to see what are the contributors to these ratings, and again found that things like fatigue and stress accounted for most of the variance in the patient-reported outcome cognitive concerns in breast cancer survivors, while clinical factors like age, smoking history, and the amount of chemotherapy received accounted for the most variance in the cognitive test results. So what are some of the possible reasons for the discrepancy between these two? Costa and Fardell generated a list of these in a review that was published in JCO. And they identify things like perceived cognitive function assessment tools have poor validity. Maybe that's the reason. Maybe these perceived cognitive function PROs assess function in everyday activities. So they're a little more robust to actually what's happening in day-to-day life, whereas the objective cognitive tests assess performance under optimal conditions on a single occasion. The objective perceived association may be stronger for some individuals than others. That is, other variables may be moderating an individual's ability to report concordance between these. The accuracy of perceived cognitive function may depend on the cognitive function itself. So some patients are so cognitively impaired that they may fail to have insight, for example. Cognitive domain comparisons may be mismatched or insufficiently specific. So we may be asking about general cognitive concerns, but we're using a specific memory test, for example, and that's reducing the relationship. Perceived but not objective cognitive function assessments involve cognitive processes involved in several self-reports. So there may be metacognitive processes that are different between patients that could be leading to discrepancies. And perceived but not objective cognitive function is prone to expectancy effects. So if we tell people that this may cause toxicity, they may start telling you that they're experiencing toxicity. An objective and a perceived cognitive function assessment tools just capture different constructs. They're both valid, they're just doing different things. So Oralman's reports across cancer patients the rates of self-perceived cognitive functioning difficulties. And you can see in comparison to the dark bars, which are age and sex-matched normative population controls, that survivors with many different forms of cancer are reporting reductions in cognitive function. Cognitive concerns were probably more commonly, with medium effect sizes, reported in thyroid, lymphoma, and multiple myeloma survivors, which may come as a shock to many people. They also demonstrated that these cognitive concerns were more common in younger survivors, and that those cognitive concerns were associated with ratings of lower role in social functioning and lower quality of life. So then they ran 3 regressions to determine predictors of cognitive concerns. The first was including just sociodemographic variables in predicting cognitive concerns. And they found that individuals who were single and had higher education were reporting more cognitive concerns. They then included clinical characteristics. And what they found was that in addition to being single and having higher education, having received chemotherapy and having comorbidities was associated with reporting more cognitive concerns. This all seems to make sense. That accounted for about 8% of the variance in the cognitive concern inventory. When they then included mood and fatigue variables, all of the variance in cognitive concerns was statistically significantly related to mood and fatigue concerns, accounting for 37% of the variance in the rating scale. So mood and fatigue seem to account for the most variance in patients' reports of cognitive concerns, not sociodemographic characteristics and not clinical factors in this particular study. There's been another systematic review and meta-analysis of breast cancer patients demonstrating that the prevalence of self-reported cognitive concerns is 50+%. But there doesn't seem to be a decrease in time. And in fact, this may be increasing in time, as you see on the left, the graph on the left. Similarly, the neuropsychological testing literature says about a third of patients develop a cognitive test measurable cognitive toxicity after chemotherapy. It also seems to persist beyond treatment. It has a tail, but it does seem to decrease over time, suggesting some recovery. So why this discrepancy? We've just modeled this with some dotted line diagrams. Obviously cancer therapy can contribute directly to these objective cognitive impairments, as well as subjective cognitive concerns. But the relationship, the dotted line relationship, is fairly weak between subjective and objective cognitive measures, as we've gone over a couple of times here. And the relationship between fatigue, mood disturbance, stress, and sleep disturbance also fairly weak as it regards cognitive tests, but fairly strong as it regards these subjective cognitive concerns. So there's been a couple of studies that have tried to untangle this, and I'm going to present them to you, and then at the end, ask you to think about them yourselves. So this is a prospective longitudinal trial in which breast cancer patients who received chemotherapy and non-cancer controls were followed longitudinally in an NCORE trial. The FACT-COG was used, and what we saw was there was some pretty significant declines in the chemotherapy-treated patients on the FACT-COG, and greater changes in cognitive concerns at that time were associated with depression, anxiety, lower cognitive reserve, and were associated with more overall cognitive concerns. This is a study that was pretty ingeniously developed to see whether or not part of the reason we have this discordance is because we're not measuring people out in the real world when lots of other life events are happening. So this group from Moffitt, led by Veal et al. And Brent Small, again, enrolled breast cancer survivors who were previously treated with chemotherapy, and they completed both in-person cognitive testing, cognitive concern ratings, mood and fatigue inventories, followed by remote ecological momentary assessments in daily life that were done on their phone, in which they completed cognitive tests, cognitive concern ratings, mood and fatigue ratings 5 times a day for 2 weeks. And at the end of each day, they also reported how many specific memory lapses they had that day. Did they have one, yes or no? So if you look at the data from the in-person visit, there was no association between the cognitive tests and the cognitive concerns. And the cognitive concerns, again, were correlated with depression at a very high rate. When you look at the remote EMA, there was no association between the in-person or EMA cognitive tests throughout the day, and at the end of the day, patient-reported cognitive concerns. So we're not seeing it out in the wild. The cognitive concerns were higher when patients were also reporting fatigue. Mood ratings were not associated with cognitive concerns. And at the end of the day, if you identified memory lapses that day, that was more likely to be predicted by a regression model that included older age, more education, longer time since treatment, and slower processing speed that was obtained both in person and on the EMA tests. And it was also associated with greater daily reported depression and fatigue. So this study seems to suggest that there's little evidence that patient-reported outcomes of cognitive concerns better align with daily life experiences. And maybe the problem is the nature of the questions. When we ask about things like, have you had a specific memory lapse today, that was associated with cognitive function a little more robustly. In this particular study, we wanted to see whether or not we could address the issue of these typical clinical cognitive tests are just not sensitive enough. If we use experimental neuroscience-based tests, we're going to get a better association. So enrolling 80 breast cancer survivors and 80 healthy controls who completed patient-reported outcomes of memory, depression, and fatigue, as well as performance-based experimental cognitive tests, tapping into these constructs of retrospective and prospective memory. And for those of you who don't know this, prospective memory is your ability to remember that you're supposed to do something later. I have an appointment, I'm supposed to go pick something up. I went into a room, what it was I'm going to go get again. And these sound a lot like the sorts of complaints that we hear from our cancer patients, this sort of prospective memory forgetting, whereas they remember, their family, what they did last week, things like that. So they argued that we'd probably see greater deficits in the prospective memory compared to the retrospective memory task, and that this is part of the problem. So what they found was that the breast cancer patients had more patient-reported outcome problems with prospective and retrospective memory, but that was not true after we adjusted for depression and fatigue. They found that the breast cancer patients were performing worse than the healthy controls on the prospective and retrospective memory tasks, with no difference between the tasks. So that task specificity or that cognitive process specificity was not found. And when looking at the patient-reported retrospective and prospective memory concerns, these were not correlated with their actual performance on the cognitive tests. So results from these experimental neuroscience tasks are consistent with clinical neuropsychological tests, and there is no evidence for a mismatch between the patient experience and the test demands that account for these perf-o-pro discrepancies. I thought this was a really ingenious study that really blends kind of clinical psychological practice with clinical neuropsychological practice. And Rena et al., very recently, just this year, looked to see whether or not personality traits are part of what might be explaining these discrepancies. They assessed worry and mindfulness in breast cancer survivors, and then they enrolled them and put them through 2 days of in-person assessments in which they randomized patients, not patients, the survivors, to receive a typhoid vaccine or a placebo. And this typhoid vaccine induces some inflammation, some sickness behavior. And they had assessed them longitudinally across this day for 9 hours, pre-vaccine, and for the next 7.5 hours with patient-reported outcomes of memory, attention, fatigue, as well as blood draws. And at the end of the day, they had them do some cognitive testing, looking at memory, attention, and sensory testing, looking at pain tolerance. And I'm not going to talk about the pain component. They did this twice with a crossover. What they demonstrated was that pre-injection worry and mindfulness were not associated with patient-reported memory or fatigue, but higher worry was associated with reports of attention or concentration problems. And higher worry and lower mindfulness was associated with more post-injection reports of focus and memory problems that seemed exaggerated in their language during the vaccine. There were no effects of worry or mindfulness on the cognitive test results of memory or attention. So what does this mean? This means when you have personality characteristics of high worry and low mindfulness, you're unable to remain calm and at peace in that situation, to find strategies, to think about options. Instead, you become hypervigilant about these issues, that these maladaptive emotion regulation processes alter the perception of cognitive function. So this was also true of pain experience. So when they were treated with the typhoid vaccine, they produced hyperalgesic reactions in their self-report to pain. So the suggestion here is that mindfulness-based stress reduction strategies during survivorship can decrease worry, increase mindfulness, and hopefully reduce cognitive concerns. Maybe it's just the way that we're using our statistics. That's the reason why we're not seeing the association. So there's been an argument from Yulin Lee that the traditional method of aggregating all the items on a patient-reported outcome into subdomains, like the FACT-COG and many other tests do, in order to show that they're reliable, valid, and they have a certain factor analytic structure, and then look at these associations with Pearson correlation, is an inappropriate way to do this, or is less robust than perhaps a latent regression Rasch model approach, in which you model the individual items on the questionnaire. You look at the pattern of items. You differentially weight the items. So infrequently endorsed items by the population, when someone does endorse one of those items, that item counts more in their overall rating of their concern. And then you calculate regression equations from this. So they compared traditional Pearson correlation analyses with a latent regression Rasch model approach. It used Markov chains to yield the entire Bayesian posterior distribution, right? A lot of words to say they did fancy statistical analyses on breast cancer survivors. And what they found, you can see on the left, is the latent Rasch regression analysis, and on the right, the traditional Pearson analysis. There seems to be very minimal differences in the slope. So while it was somewhat better, a small improvement in the predictability of these concerns, that modeling approach, a very sophisticated modeling approach, didn't seem to close the gap between these two. Also recently, Kathleen Van Dyke has used a machine learning approach to see if that would maybe improve our ability to identify relationships between the PROs and the cognitive tests. And they took a population of older breast cancer survivors who had been followed over time and healthy controls. And what they're able to do is group these breast cancer survivors into individuals who had reported cognitive concerns for 2 years and compare them against healthy controls who had not reported any cognitive concerns at all on the FACT-COG PCI. They used machine learning methods then to predict group membership. And what they found was that there was a small constellation of small changes on cognitive tests from baseline to 12 months that distinguish cognitive concerns from normal individuals. When you look at the table of the 10 variables that contributed the most to these models, you'll see that measures of attention, learning, and verbal fluency were commonly amongst the highest ranked variables that were separating the groups. So we think, okay, great. If you have cognitive concerns, you're going to have some cognitive deficits, although they're small and they're across a lot of different variables. When we use machine learning, we can pull out that variance and see that there really is this relationship. And that's true for a number of these tests. But what is, I think, confounding in machine learning is that it doesn't really care what direction the variable is going in, right? It finds the best fit. And unfortunately, for a number of tests, for example, the memory and the verbal fluency test, the normal controls were doing worse than the cognitive concern population. So it's not consistent with cognitive concerns being related to cognitive impairments. So again, we come back to this last question. This is the end: to test or not to test. And the questions are really around, do we think cognitive PROs and cognitive tests are interchangeable, right? Can they be surrogates of one another? Are clinical grade cognitive tests incapable of measuring cognitive function in this population? They're too insensitive. Which should be utilized in a clinical trial to determine the effects of a treatment on cognition? And if we utilize cognitive concerns, patient-reported outcomes, does that mean we also need to utilize measures of anxiety, depression, fatigue, and personality? As I think we've demonstrated that we need to be modeling that to account for that. And at the end of the day, who decides? Who makes this decision for the clinical trials? So with that, I thank you all.
Question.
Wonderful presentation. Thank you. I've often wondered when we are doing repetitive mental status evaluations of one form or another, are we teaching to the test? So when you look at your control group and your treatment group, have you noticed an improvement in scores just because of the repetitive nature of the testing?
So one thing, yeah, there's a lot of questions. Let me unpack that. Number one of the things that we do is we use tests with alternate forms so they can't learn it. So when you do mental status testing, like the MMSE, and you're asking for the date, right? And they're like, oh, I know this time they're going to ask me about the date. Like, let's practice, right? Let's make sure I know it. And you see those MMSE scores improve, of course. There are some studies in which we've looked at healthy controls and cancer populations, and what you see is a failure to acquire a practice effect in a cancer population as well. The healthy controls can get better, and the cancer patients may not get dramatically worse, but are not getting any better. And that absence of a practice effect can be interpreted as a cognitive deficit as well. But most of the data that I'm showing you, that's not what's happening in these populations. They are having demonstrable declines in the face of repeated testing.
So I have actually, first of all, that was a fantastic talk. I have two questions. One is, related to sleep and sleep interventions and, what kind of effects those have had in terms of improving cognitive function, because obviously it's super hard to disentangle the two, as you've pointed out. And sleep has such a profound effect on so many other aspects of well-being and cardiovascular health and everything else. So I just didn't know if there had been any interventions in that space.
Yeah.
And then the second question I had was related to some of the personality components. And if you tell people that they're doing better on the tests over time, does it actually affect performance in any way, or patient-reported outcomes of their personal impression of cognitive worry?
Yeah, great questions. Sleep. So obviously there's not a single thing that impacts cognition and only a single variable that impacts cognitive concerns, and sleep and fatigue impact both to different degrees. So and I think we probably underappreciate the extent to which sleep and sleep disorders are adversely impacting our survivors and our patients. So I think it's it's an important thing for us to identify clinically and to try to help them manage and cope with. There have been some studies that have tried sleep hygiene approaches and sleep interventions, and it could also be things like blue lights and things like that. And they have demonstrated that in some survivors, there are definitely effects on subjective well-being, and there are even some measurable effects on some objective outcomes like cognitive tests as well. In terms of personality traits and how this relates to encouraging endorsements of problems or impacting the patient's performance, there's a few studies and they have conflicting results, and they were done in the same lab. So there's still a little bit of lack of conclusion here. But the general idea comes out of really a traumatic brain injury model as well. So we knew in mild TBI, if we told people that they were going to have a hard time recovering from their deficits, they never did. They had persistent and mild TBI or persistent post-concussive syndrome. But if you assure them that they're going to get better, you dramatically increase their ability to return to function. And this concept of stereotype threat is part of what we're talking about here. And so there's been studies that have informed breast cancer survivors that chemotherapy can cause adverse cognitive effects, and then they tested them and measured their cognitive concerns, and that seemed to potentiate cognitive problems. And so there's now some concerns about, should we really be telling people this is a problem? But again, on repetition, that result was not maintained. I don't think it's probably ethically fair for us to say, don't worry about it, chemotherapy is not going to do anything, right? But I think we do have to be mindful about the fact that that our words and our ideas can shape their attitudes and behaviors as well. Yeah.
If I can cut in a little bit, my neurosurgeon, I'm a brain cancer survivor. I've had 2 surgeries, right frontal both times. My neurosurgeon at Mayo, when asked what I could expect as changes, he said, if you take her to Vegas, she might be a little bit more impulsive. But I've had profound changes, undeniable changes in processing speed and attention and lots of things. And actually not being told that that would happen was disastrous. My boss told me I was lazy and dumb and slow and just not trying hard enough. And I believed him because no one had warned me that that might happen. So I had to go out and beat the bushes and find my own treatment team. And the first neuropsychologist that I saw said, oh, didn't you know this is all expected? This is normal. You'll learn to compensate for this. Everything you're experiencing is normal. And that's the biggest moment of my life, being told that. So I didn't know what to expect. And I thought it was on me. I thought I was being lazy and just not caring enough. So I would argue that it is important for the patient to have some understanding of what to expect, because I didn't get help for 6 long, dark months because I didn't know that there was help or understand that I needed it. So you do not want someone with cognitive dysfunction Googling whether or not they have a brain injury and whether or not they have cognitive dysfunction. That is not an effective way to cope.
Yeah, no, I totally agree. I think 25 years ago when I was coming into this field, it was very uncommon for the oncologists to understand that these issues were there and to spend time talking about this. That was my experience. But I think recently, I think this is certainly a topic that's on everybody's mind. And I think patients are given a lot more information now and a lot more resources, which I think is really wonderful, like you said.
Yeah, I had surgery 2 years ago at Mayo Clinic in Rochester, done by the chief of neurosurgery at Mayo. And afterwards, when he came by to check on me, he said, you look great. And I said, well, I feel like I'm inside of somebody else's mind. It's really unnerving. And he said, well, you can walk, you can talk, you're alive, you're welcome. So from his standpoint, I was fine. I could walk, I could talk.
Yeah.
From his standpoint, I was perfectly fine. But from my own standpoint, not so.
Absolutely. Yeah. And maybe, the importance of multidisciplinary care as well. Yeah. I'm glad you found some neuropsychologists to help.
Oh, good grief. Me too. I ended up working another 10 years in a demanding technical profession because I had gotten that help and learned that I needed to relearn some aspects of my life.
Good for you.
Yep.
Thank you.
Can I just ask a quick question? And maybe I misheard, but group into the diagnoses that had cognitive or other issues was thyroid. Right. Is that what's on your, and so thyroid, unlikely to get chemotherapy and more likely to just have low thyroid hormone. Was that sort of?
Nope. So this was just giving these survivors of different cancer types a cognitive concern inventory, and they were reporting high levels of cognitive concern. So to your point, maybe they just had fatigue, but they were saying they also had cognitive.
No, it's real. I'm
not for sure
that, but it's probably different in as far as how one could simply treat that population.
Yeah.
Great.
So Jeff, Lynn and I were talking about how do you budget for this? What is 30 minutes of, properly done, the CTV? What should be budgeted for that?
Like money wise in a clinical trial, things like that. Yeah. So the vast majority of those studies that you see on that table, I do for free. That's the research that I do, right? I go out and seek grants to be able to help fund my lab to do this, like BISQUIC funding. Cooperative groups are not in the habit of funding investigators, right? So there is mechanisms at the NIH, like the BISQ-SFP, that allow you to apply for funding for individuals who need that in order to support their ability to work on a clinical trial. I am just really fortunate to be at MD Anderson, which covers a little bit of my time, and to have secured funding in lots of other places and then be able to distribute that across activities like this. The sites themselves, of course, get the usual compensation. I know within NRG, and I'm not exactly sure what's happening with our trial in SWOG, some sites receive additional case credits and additional compensation if they can participate in the QL component or in the cognitive component, and that's how sites can be incentivized to participate in that. But clearly, one of the challenges at a lot of different sites is staff time. So this takes a little extra time. It's not part of the regular care workflow, right? So I think that's probably as important of an area to think about. How do we make this feasible at our sites within our cooperative groups?
Thanks.
So in terms of interventions to address cancer, chemotherapy-related cognitive impairment, do you think it's probably more pharmacologic or lifestyle factors like diet and exercise, or behavioral interventions like games or puzzles that engage the brain? Like, what do you think looks the most promising right now?
Yeah, no, those sound great. Yeah, let's do all of them. Unfortunately, we don't really have a empirically supported therapy for this. And part of that goes back to that mechanism slide. We're not quite sure what the mechanism is that underlies these problems. So most of the interventions at present are symptomatic. You have a processing speed and attention problem, maybe a psychostimulant will be helpful for that. You have fatigue, maybe sleep hygiene and exercise will be good for that. In general, exercise seems to be good for everything. You additionally are stressed. Well, maybe stress management would be helpful. And maybe many of these pulled together will seem to benefit in different ways: cognitive function, cognitive concerns, quality of life. There have been some studies that have looked at kind of medical-based physical activity like yoga for cancer survivors and some mindfulness techniques that have shown that it can boost some areas of cognition, some aspects of cognition in breast cancer survivors. So I think those are promising. But they're not really conducted in very large phase 3 RCTs. So we'd say like, definitively that's happening, and it's happening by this mechanism as well. So a lot of the work right now is in preclinical labs trying to understand what are the mechanistic pathways in the mouse brain that we could then translate to the human brain. And maybe we could develop biologically rational targeted therapies to prevent this from happening or ameliorate it at a restorative level and not a compensatory strategy level.
All right, one last question. You mentioned early on about a broad category of observer-related outcomes, and I guess I really hadn't thought about that per se. We're used to thinking about clinician-reported things and caregiver-reported things as I guess they're part of observer-related outcomes. But yesterday in this room we had a cancer care delivery research meeting, and Ravi Parikh from UPenn talked about a study that involved lay health workers who are going to be interacting with patients to try to help them achieve goal concordant care. And do you think lay health workers could be a source of observer related outcomes for cognitive function, and has the link between that kind of unbiased, less biased observer and measured cognitive function ever been tested?
In pediatrics, right? So there, you're not asking the child, do you have attention problems, right? You ask the parent and the teachers, fill out these scales to tell us whether or not they have attentional problems. And that's a really important aspect of diagnostics in pediatrics. Not as much work has been done looking at caregiver opinions on cognition of their spouse, maybe, for example, and to see whether or not that provides a more true estimate. I think what you'll find is all those same variables that confound the individual rating their cognitive function are also going to be related to the perception of cognitive function from a lay provider. So are they stressed? Are they distressed? Are they concerned? Are they worried? Do they have a personality style that catastrophizes? So on and so forth.
I see. So even if it's not a caregiver or a parent, you think like a lay health worker observer would carry forward those same problems?
So I think one of the issues there has to be like over what period of time are they observing them in what settings, right? So if they just see them walk into the clinic and walk out of the clinic, I don't think we're going to get much value out of that.
Gotcha. Okay, thanks.
Yeah.
Well, thanks so much.
You're welcome.
All right, well, next up, our own Ria Vaidya, who's our senior staff scientist from Fred Hutch and leads our PRO core committee. And she's going to talk to us about PRO in treatment trials and some of the work she's doing.
Right. Good morning, everyone. Thank you, Mike and Lynn, for the opportunity to talk about our PRO core and the PRO process. I'm trying to keep this talk brief because it's a process talk. It's early in the morning. I don't want to bore you all, but if you have any questions, please feel free to ask or email later. So a little bit about SWOG's patient-reported outcomes core. I know many of you in this room have heard about it before, but this is it's not a committee, it's a group that provides scientific oversight and input to PRO design and SWOG trials, both on the NCTN and NCORP side. So part of what we do is build a process to include PROs so we have a more kind of standardized flow of things from the conception of the proposal to all the way through to analysis. We maintain that process, update it as needed. We review all new studies with PROs and also manage resources, budgetary resources that are available for PRO studies to make sure we can do all of the studies investigators are interested in. And then the other piece of it is we also look at the logistics of managing PRO data. So this is everything from helping investigators write protocols, study build, getting permissions for all of these PRO instruments, monitoring the data once the study is active, doing analysis, all of those things are covered. In terms of membership of the PRO core, so this is just a list of our standing members. So we have several people from our NCORP leadership. We have members from our stats and data management team, and also from the SWOG operations office. In addition to that, we also invite rotating members to join for a brief period of time. So if any of you are just kind of interested in learning about how PROs work in SWOG or just being a little bit more involved beyond an individual study, please feel free to reach out to us and we can get that going. So what I'm really going to talk about today mainly is our standard operating procedures. And we've had these in place since 2019. It's a resource document that helps study teams, include PROs, everything, what to do from the beginning to end. And we've recently been making some updates to it to, cover a lot of things that we hadn't previously covered in as much detail or new things that came up since. So in terms of the structure of this document, it addresses both the NCTN side of things, PROs in those studies, and then the NCORP side of things. So yes, the key things that are new is we talk a little bit more in the SOP now about our process for NCORP studies. There's more detailed information on permissions. We made some changes to the process there since the last time this SOP was written. So more about permissions and then a few things that have come up in the interim that were previously not talked about. So I'll talk about NCORP studies first, since that's of more bigger interest to this audience. So in our in-group studies, almost all of our studies, we have PROs in some form, in many studies as primary endpoints. So we're not making any changes here to the study development process. The study development process is what it is, but what we ask is basically early on in the process, and we clarify timelines and things like that in the SOP document. But really, investigators and study teams should come to the PRO core as early as possible with the study concept, all of the PRO plan, and just have it reviewed so we can, take a look at what your PRO plan is, see if there are any instruments that maybe shouldn't be used, or maybe there are other instruments that may be better fit for the study, look at the PRO burden, make sure that makes sense, those kinds of things. So just kind of recommendations for how to move forward with PROs for the study. And then in the protocol development stage, the big thing to look at will be following the PRO permissions process. Permissions, and I know Katie Arnold, who helps coordinate a lot of permissions for the studies, will want me to say this to you. You just do not even think of using PROs in your studies unless you've got your permissions in place first. So what the PRO SOP covers is like how SWOG handles PRO permissions. So just very briefly, Katie Arnold at the Stats Center helps coordinate all of this permissions process for all of the studies, NCTN or NCORP. And she works with SWOG staff and legal and contracting to make sure everything is in place. If there are any fees involved, we've talked through those, figured out how to budget for those, how to pay for those things. And we have more information in the form about whom to reach out to. We have sort of this new template document for investigators to provide information to us about PROs, so we can get all of that permission stuff moving smoothly. So all of that is in there, and all of these things, the licensing should be in place before any PRO data are collected on the study. So as soon as the study is in the protocol development stage, the permissions process needs to get going. For treatment trials, so here PROs are mostly going to be secondary endpoints for the study, and this is like a very simplified version of the process. There's a lot more detail in the SOP, but really it starts with, so when the clinical concept is being developed in the disease committees, we ask that hopefully simultaneously with that, the PRO proposal will be developed by the study team and will come to the PRO core so we can review it, make recommendations. And then as the study moves along through the SWOG kind of capsule process and review process, the PROs get incorporated in there. The SWOG executive committee reviews the PROs. Then all of that information, the clinical concept with the PROs, goes to the NCI for review. And then once the NCI has approved the study, that's when PROs go into the protocol. So at that point, all of the factors with permissions and study build and all the sometimes more detail in terms of the PRO study design, all of that comes in there. So this is just a very high level overview of the process. So again, this process, like I said, has been in place for a while, but things that have changed in that current version of the SOP is we have more information on the timing of the PRO proposal submission. Again, how early should you come to the PRO core with your proposal? If your study is kind of already approved and you're already writing the protocol, but the study team decided late, like, hey, we want to add PROs now, what do you do? So those kinds of things. So we just made that clearer. And we've also aligned with other process updates in SWOG. So, maybe some capsule formats have changed. So kind of how to make sure everything aligns with that. Permissions processes, how to add PROs to your study after starting protocol development, things like that. And then one of the key pieces that we had not talked about before was what happens to studies that get redesigned. So sometimes you have a clinical concept that may have PROs, that may not have PROs, that goes to the NCI, does not get approved. And then the study team just kind of redesigns the whole study. So in those situations, you don't want to bring that study and the new PRO plan back to the PRO core for review. It may have been reviewed before, but we still want to see that, hey, things have changed about the study. Maybe there's an additional treatment arm, maybe there's a new treatment, so that do the PROs still make sense in that context? So just kind of, bring it back, get it reviewed. So yeah, that's pretty much a summary of everything that has changed. And I want to thank Crystal Meva and Mariah Norman and Katie Arnold, who've helped out a lot with getting all of these pieces in place. And we'll have the new SOP document and the new other supporting permissions documents and things like that live probably next week. And for all of the fun details, if you're excited about learning more, I hope you are. Please contact either the SWOG operations office or the PRO core, and we can provide the documents and any other information you want. Any questions?
Can you tell us where the document's located?
So the SOP document lives on the kind of the SWOG operations office SharePoint. So I think it's accessible to ops and to stats, but any of us can pull it for you and send it to you.
I also just want to mention, one way to get involved in SWOG is to propose a study. Another way to get involved is to be a quality of life co-chair on a treatment trial. And so if there's anyone in the audience who is interested, say, in multiple myeloma or lung cancer or something, and, isn't actively involved in developing a treatment concept, but might be interested in developing a quality of life component, either let the committee chair know of the treatment trial committee, or let us know, because we can sort of have a list. And sometimes they'll come to us and say, hey, we're developing a new trial for renal cancer, but we don't know who the quality of life co-chair is going to be. And we can certainly propose names. So if you are interested, please reach out and let us know.
So I have one question that's not so much process related, but just more general about PROs. We're the Symptom Control and Quality of Life Committee, but we are so much talking about toxicities. We focused on CIPN and aromatase inhibitor musculoskeletal symptoms and immunotherapy toxicities, or et cetera. How many of the instruments are out there for PROs that are developed with treatment specific validation, right? Like radiation related symptom burden or BMT or what have you. I mean, how often is the PRO as toxicity oriented as we sometimes are?
Not often. And a lot of what we use tends to be a little more general or more symptom focused. So pain, but FACT definitely has a few instruments that are treatment oriented. So there's the FACT for biological response modifiers. And I believe there is one for ICIs that's being validated, but that's still ongoing, so it's not validated yet. But there are a few out there, but a lot of what we tend to use is either more general or more symptom focused rather than treatment modalities.
Thank you.
All right. Thanks all.
Thank you very much. So definitely please reach out. We have, there's an email address. We can make sure we get that information out. But if you do have any questions about the process or you're interested in getting involved, please speak up. So next we want to move on to updates on our currently open trials. Jill Hamilton-Reeves wasn't able to attend the meeting today. She's the study chair for 1600, but the great news on this trial is it reached accrual. So as of October 5th, she made it to 201 out of 200. So it is now closed to accrual. It's a relatively short intervention. It's just peri-surgical. And so they will be able to hopefully look at the data and get results out there relatively quickly. So we want to congratulate the team. We want to thank everybody for this took 4 years, took a long time. It was all through COVID. And, they did a great job. So thank you very much. And thank you to all the patients for participating as well. So next is SWOG 2013, and I know Dr. Genturu is online.
Thank you very much, Dr. Henry. Now we can go to the next one. So this is I Check It, or S 2013. On behalf of the team, I would like to thank all of you for enrolling onto the study and to all our participants. So just to refresh your memory, this study is to develop and validate a risk prediction model for IRAEs in participants receiving immune checkpoint inhibitors for solid tumors. Remember, this is only for ICI treatment, and they should not be getting any chemotherapy or targeted therapy. Next slide, please. So the translational objectives, one is tissue sample at the registration of the study. This is optional again. And blood and stool samples at baseline 4 to 6 weeks and at the start of grade 3 or higher toxicities. And thank you very much for encouraging all your participants to sign up for these. Next one, please. So our accrual goal is 2,062. The study was activated in August 2021. So far, 70% of the accrual goal has passed, and we're currently enrolling at least 80 to 90 per month. So just to show you where we are right now, lung and melanoma are the highly accruing subsets in this study. Next one, please. So what we're planning to do, next amendment, we're separating the consent for the blood and stool specimens, given a little bit of hesitancy with the stool specimens. And we're working with NCI to add another chemo ICI cohort for lung, GI, and breast cancers, not melanoma. That's my mistake there. And also adding dietary fiber survey to evaluate the association between fiber intake and how it correlates with immune-related adverse events. Next slide, please. So what we'd like to learn and get your input from is how we can increase the minority and rural population enrollment. Currently, we have highest accrual from lung and melanoma, and given melanoma is the highest seen in white or Caucasian, that also could be contributing. We're wondering how we can increase the minority, and if things go well, if we open the chemo ICI arm, and how we can proactively make sure that minority and rural population will be enrolled. Thank you. I'd like to hear your thoughts.
Yeah, so if anyone has any comments on that, also if anyone has any comments about challenges that they've been having, especially with sample collection, we would like to hear about that as well.
Hi, Krista Brown Inglis from Hawaii. We are currently trying to open this study. We had held off on it originally because of staff shortages, but we're concerned that it's accruing so quickly that we may not, get it open. So we're trying to fast track it and get it open, but that will help your minority accrual. And I do think if you open the chemo ICI, that will help us too, because there's another trial in another cooperative group that we will not be opening because it's looking at African Americans versus whites. And so, yeah, that's our recommendations. If you could keep it open a little bit longer and add in the chemo ICI. Thanks.
Yeah, thank you very much. And we are, as was mentioned, we are hoping to add on this additional cohort. There's a lot of different factors that go into it. It's not entirely our decision. And so, but we are hopeful that we will be able to leverage this sort of as a platform trial to be able to learn a lot more about chemo ICI as well as ICI alone. But thank you very much for your support, and we look forward to your site getting the trial open.
Sam Wright from Carl Cancer Institute. Also the ORP liaison for this committee. Definitely adding in that ICI chemo is definitely going to help. Separating out the blood from the microbiome specimen is definitely going to help as well. At our site, we have had an issue with the poop. So patients initially will say, yeah, that's fine. And then when it comes down to it, they don't want to do the microbiome collection. So separating those out is definitely going to be helpful for us.
Thank you very much for all your support, Sam. Anyone has a pull at NCI, we welcome your petition to NCI for chemo ICI arm too.
I know when we were talking about this issue of people not agreeing to either because they don't want to do the microbiome collection, I know that there was actually, it was stated by someone in our committee leadership that you actually could still allow them to collect blood, but I don't remember the details.
I think Amy was one. Amy, are you on the call? Amy Dark? I think Lynn, Amy had some detailed instructions.
We can certainly try to send that out because I think there was a way that you could get around it until we get the amendment through, but we are hoping to get the amendment through as quickly as we can. Banu?
2 comments. One, if we could go towards a hub and spoke model, you would get more rural participation in all of these studies. I mean, I just started opening SWOG trials, and it takes an enormous amount of effort to open one trial. We opened a trial and it stopped accruing Caucasian patients like a month afterwards. So if you really want diverse participation, you're going to have to work towards a hub and spoke model. And I wanted to call to your attention that there is a rural need for specialists who can mitigate IO therapy side effects. I've had 3 patients nearly die now of immune therapy side effects, and I can't find a specialist to take care of them. So you should be aware of this as you try to recruit for this trial. I mean, it's an impediment. If I know I could kill someone, I'm a little hesitant to start them on checkpoint inhibitor therapy.
I guess to that point, similar to Meghan Jens's trial for remote tumor boards, has anybody thought about, or could there be an appetite for management of IRAEs in the similar kind of remote tumor board model? Because, it's a vast amount of experience, but it's also a lot of rare experience, having had also been in that circumstance of putting somebody into fulminant liver failure, it just takes one, right? So I don't know, maybe worth thinking through some kind of, symptom management tumor board kind of model.
That's a fascinating idea. It's definitely worth thinking about. Our committee, has been interested in important observational trials like, S1714 and now this S2013. I check it, but I wonder what. Well, patients have maybe a different attitude about prospective trials, right? These are observational trials where there's no personal benefit involved. It's altruistic to be involved and to give your blood and your stool and data and just the whole, the whole paradigm. And I wonder what your experience has been in recruiting to these different kind of trials, and whether there might be differences between certain kinds of patient groups, whether it's rural, urban, or based on age or any other subgroup. What your experience has been.
Sam Wright from Carl again. We have participated in quite a few of these types of studies, and we find the presentation to the patient during the teach is key. I mean, for this trial as well as the Alliance trial that's kind of similar, when we enroll them prospectively, when they start their therapy, we tell them, we want to be able to see which type of patient is more likely. We don't know that unless we look at the very beginning. Patients seem to understand that a little bit better. They're a bit more on board. I think having the specimen collections at time points where they're already getting blood drawn, they're already doing whatever, they're already coming into the clinic, that certainly helps because they don't have to do anything extra. With PRO inclusion, we also give that to them while they are sitting in the chair for their infusions. We like to call it their homework. Or if we're talking about neurocognitive testing, their fun and games session. So it's all in the phrasing we find.
Well, thanks. I think that's great. And so it occurs to me that that you're not just tapping into their altruism per se, but you're engaging them and they're having a different experience of being assessed and sort of being engaged with the team when they enroll in these trials as well. So maybe there's a perceived sense of benefit to that is part of their decision making.
And I think a lot of them really like having something to do instead of just sitting in the chair, staring at other people, usually.
Krishna?
Thank you.
Thank you, Lynn. So one question going back to Don's comment about the tumor boards. I would be interested because I hear this from multiple referring physicians about the immune-related adverse events and not having enough support. So my question for Don and to Lynn and Mike is, do we need to do a study like with the tumor board, just like the plenary yesterday, the molecular tumor board, or is it off study? Or we can talk about it later too.
Or is it just a matter of asking ASCO to make a panel of specialists who are willing to consult by phone available to all of us in the rural area?
Yeah, maybe the ultimate answer would be some of both. I mean, many times it starts with research before you get ASCO to, invest in things. You figure out how to do it and what the benefits are. And maybe if we have a clinical prediction rule, we can figure out, how to select, the people who are most at risk and apply resources in the most efficient way. Yeah, so we'll have to think through all that.
Lauren Nye from Kansas, just speaking to the rural aspect and collection of some of the specimens requested, like stool, where that's not necessarily something somebody does on command when they're at the cancer center, but also not something someone wants to drive 3 or 4 hours back to you. So coordinating, getting them whatever collection kits with greater ease ahead of time. Maybe it's the number of kits a site can have at a time or things like that. Would really help us. I've done studies with stool as well. It's always a clincher as to if that's going to turn someone off, but most people will do it if they can do it in their own home. And so just thinking about what we're asking them to do and where.
Just echoing the sentiments about accruing patients to the observational trials, talking about them, how they can participate, especially with the minority patients, knowing that they're going to be representative in these trials. And I think that's why we decided to push forward and open iCheckIt, because we're realizing we're not getting the representation in that trial if we're not accruing to that trial. So thanks.
Thank you very much. We'll take all this feedback, back as we're talking about it. We definitely want to try to maximize the knowledge that we can gain from this trial. We don't want to lose out on blood specimens if people aren't interested in giving stool specimens. And so we will be, as we have the amendment going through, but in the same time, we will reach out with more instruction, and we'll see if we can figure out a way to be more flexible about the stool collection, and make sure that we reinforce the instructions that we already have to make sure that they're apparent, because I know it gets buried in the protocol sometimes. So thank you. So we will, that's the study team. So we will move on to Dr. Melissa Accordino's ice compress study.
Thank you. So no stool collection with this study. So this is our limited institution ice compress study aimed at trying to find a successful intervention to prevent chemotherapy-induced peripheral neuropathy. Here is our schema. This is for patients starting one of the 4 taxane-based regimens. They're randomized 1:1:1 to cryocompression, continuous compression, or low cyclic compression. And as of last week, our accrual was 33 patients out of 777. We recently opened this study not that long ago, and most of the sites started going through their training in June. So we are pleased with how things are going. And here's the breakdown by arm. We have an amendment that is going through, and part of this is to expand the timeline of baseline assessments. We originally wanted baseline to be completed within 14 days. We're going to expand that window to 28 days to make this more patient-friendly. We are also going to clarify the language about when we need to do the sensory and motor testing and the biospecimen collection, which is blood. Also to specify that the patient-reported outcomes must be done before randomization. And then just to clarify that we do want to try and keep the assessments on the same day as the taxane infusion if possible, but we do know with patients getting delayed that sometimes to keep them within windows that this is not always possible. And then there have been some questions about the AE assessments. We are doing AEs with every taxane infusion, and we are collecting all cutaneous toxicity, cold intolerance, burn, rash, and frostbite for all the time points. So those are the specific AEs we're interested in. We are also collecting any AEs that the investigators believe are possibly related to the device. We know patients will have AEs because they're receiving chemo. So if they're having nausea that is from the chemotherapy, we don't need to collect this. It's really just safety issues related to the device. And here are our contact information. What I do want to highlight is the bottom right corner for study device questions and contacts, including real-time communication with the Paxman team. I know that there have been issues at sites with some of the devices not working the way that they're supposed to. Please keep us informed. The Paxman team has been very helpful at trying to troubleshoot in real time. And hopefully, as we get more used to these devices and more comfortable, we can work the kinks out. And that's part of why we are doing the study, so that we identify what these kinks are, that hopefully we can find a successful intervention and we can provide this for our patients. So, thank you.
I was going to ask you a question. Have you personally or heard any experiences in trying to recruit patients, the informed consent process, and whether some patients have, not gone on the trial and you kind of got a sense of what their concerns were? They couldn't imagine getting frostbite and they were turned off or whatever it was.
So it's kind of, at least for me, it's been a mixed bag. I've had patients where they say, I just want to get my device on Amazon. Like I want to do my cooling gloves, so I don't want to do this. And we have to have a conversation about what we know versus what we don't know. I've had patients that just say, oh, I don't want to do anything. I'm okay with neuropathy. And then we have to have a conversation about that. But most of the patients have been pretty willing. I think the logistics, especially in the very beginning, I think each individual infusion center has different operating procedures. And I think trying to get ours sorted out has been a little bit of a learning curve. I think we're much better we are today than we were a few months ago. But I think each individual site's going to have to go through probably a little bit of growing pains with this.
Thanks.
So I have a couple questions. One of them is, what is the rationale for having to complete the pros prior to randomization, but everything else just has to be done prior to the taxane?
So we really wanted to get the baseline information, and because the primary endpoint is changed from patient-reported outcome at week 12 from baseline, we really don't want to risk missing data because it is our primary endpoint.
Okay, this was similar to S1714, where it was like specified this had to be done after this and this before this. And, it is, from a coordinator standpoint, usually involves extra thinking and extra visits. So just a comment about that.
And then the other thing is, and we are opening the study, but we're not getting trained on the machines, which are at our site. We're not getting trained until the end of November. So recognize that I'm not intimately familiar with the protocol yet. You're now saying that you can do the initial stuff within, 28 days of starting. But most SWOG trials, and probably this one, timing goes off of registration. So what happens when you get out from that initial registration is that patients are not within window. And then, you're trying to scramble because nobody's going to come in for a cancer control assessment. I mean, how would you even bill for that? So I hope that the windows are built a little bit wide.
Yeah. So, that's part of why we expanded that window, in case patients were coming in for additional testing, if they're coming in to get their echoes, if they're coming in to get lab work before, is the potential to maybe do their baseline assessments at those times. We also know that a lot of times the baseline assessments are done the day of treatment. So that was why we wanted to provide some guidance that, yes, it's chaotic the first day of treatment with seeing the patient, they're nervous, getting them up to the infusion center, getting them accessed. As long as we do the patient-reported outcome, get them randomized, get them set up, it's potential while they're upstairs waiting in the infusion center to do the other baseline assessments like the motor sensory testing.
I'm just telling you, operationally at a community site, if there, and again, maybe there is a reason, and I understand what you're saying. You want to make sure it's collected, but I would hope it would be collected whether it was done before randomization or after. But my point wasn't even necessarily about the initial visit. It's more about the follow-up visits that are so limited. And if you get a patient, because it always goes back to registration. So if you get a patient that is off one time in a follow-up, they're off every time because they're not going to be brought back in for a cancer. They're just not going to be. There's no way to pay for that. So I just wish when it gets to the follow-up period, perhaps things could go off, the timing could go off the last visit instead of going after registration. Because I just already see that being an issue. And hopefully this protocol won't extend 2 more years like S1714 did. But anyway, thank you.
Thank you.
Thanks. We appreciate the one question. We appreciate the comment also about the follow-up windows, and we'll definitely take that into consideration. I know that there is a desire to still go off registration, but hopefully we can find a happy medium. There is a question in the chat about, are you looking for new sites for the study?
So we are collecting backup sites. We do have our 25 sites currently, but we have accepted applications for sites that might not be able to open the study. So if you are interested, Cynthia Law, can you raise your hand? So S2205 at SWOG.org, and Cynthia is your contact person. Thank you.
Thanks. Well, wouldn't it be great if when somebody tried to buy, ice gloves on Amazon, that we pop up with a SWOG trial?
Okay, so next, we're just going to do a quick update of SWOG 2010. So this is the randomized phase 3 trial comparing active symptom monitoring with patient education versus patient education alone. This trial is really focused on patients at high risk of breast cancer recurrence. So women have to be pre or perimenopausal at the time of breast cancer diagnosis, and they have to be getting ovarian suppression or ablation in addition to their oral endocrine therapy. You can see on the right-hand side, it's relatively straightforward study. We do have some windows built in. I hope they're sufficient. And then there's one phone call at the very end at 80 weeks. Just quick reminders before I switch to the next slide is if you are opening this as a new study at your site, please make sure that you have at least one staff member complete the ProCore training and also give us their information so we can give you access to the ProCore website, because otherwise when you randomize your first patient to the experimental arm, you won't be able to get to the site that starts to send them the intervention. So it's at cancercontrolquestions@crab.org. And so just thinking about the questions that we've received repeatedly. So this is stage 1 through 3 hormone receptor positive breast cancer. It can be any estrogen receptor level, any HER2 level. You just have to be planning to give endocrine therapy. Patients do have to be perimenopausal at diagnosis. We have corrected most of the parts of the protocol that were a little bit nebulous. There is still one thing that we need to fix. I apologize. Patients have to be getting ovarian suppression as part of endocrine therapy. So you can give tamoxifen, you can give any aromatase inhibitor, you can give any GnRH agonist or chemo induced ovarian failure or bilateral salpingo-oophorectomy. So the protocol is not saying what you have to give, but you do have to give both parts, the ovarian suppression and the endocrine therapy. And then we have a little bit of a window that you can enroll patients within 14 days before they start their endocrine therapy or 14 days after. Patients do have to have access either to internet or to a telephone. And then I just mentioned the standard of care therapy already. If people, just a comment about chemotherapy-induced ovarian failure, you do have to be intending to initiate GnRH agonist therapy if ovarian function returns, whether they're taking tamoxifen or aromatase inhibitor. But we do not mandate that you have to do estradiol assessments on any specific schedule. And then we did recently update, have an amendment go through. So all patients are getting a patient education handout. It's just available in English and Spanish about symptom management and healthy living. There are now study visits as opposed to clinic visits at 12, 24, 36, 48, 60, and 72 weeks. So these can be with any study personnel. They do no longer have to be with a cancer provider. You do have to remember to do the PRO questionnaires on paper at each visit. If you're doing virtual visits, you need to actually send the questionnaires to patients and have them return them to you. And please encourage people to do the optional blood draws. These are really important secondary and exploratory analyses that we would like to do. And so I just want to thank everyone so far. I think we're up to 98 out of 540. So we're enrolling well. Thank you very much. And we continue to get new sites on board. Any questions or comments about how it's been going?
Who designed your logo? That's a great logo for ESPE.
I did.
Awesome. See? Congratulations on that.
I have a tradition of doing study names that are ski resorts. So, because I live in Michigan.
Hi, Catherine Poggio, UC Davis and Marshall Cancer Center. We absolutely adore this trial. I think it's fantastic. So thank you for opening it. Something that might make eligibility a little bit easier to get patients on trial within that specific time frame, we found was looking at all different types of patients and how they get their endocrine therapy and that time frame with the injection. And I've advised my sites to look at different injection times. And so I know you sent out that FAQ sheet on eligibility criteria, but maybe sending out like patient examples of like patient timelines and like when to enroll during their timeline. But it's been pretty easy. Once you kind of understand at what point they get their injection, you can start enrolling them.
Yeah, thank you for that. And we also, I forgot to mention, we do have a monthly phone call that anyone is invited to attend, study coordinators, local study PIs, anyone who is able to make it, feel free to come. We will update that. But just to clarify, to get a little bit in the weeds. So if someone is getting a GnRH agonist injection, you can either enroll up to 2 weeks before getting that injection and then have that be the start date. Or if they were already getting the injections, you can use the start of the oral endocrine therapy as the plus or minus 2 weeks. And so we tried to keep it broad. So if people are getting either, I have some people who start their GnRH agonist injections during radiation, and then we wait until after they're suppressed and after they're done with their radiation to actually get them started on the endocrine therapy. So we enroll at this point when they're starting the oral pill. But some people just want to start it all at one time. The one thing we can't do is actually start someone after they've, I'm trying to think.
After they've started the endocrine.
After they've started, more than 2 weeks after they've started the endocrine therapy. And so some people wanted, somebody wanted to give endocrine therapy sort of preoperatively and things, and we can't do that. But you can enroll during radiation. It's just our site happens to wait until afterwards. So, but yes, I will send out examples because I know I've tried to give some. It just gets very confusing.
I didn't know if you wanted to mention some of the both opportunities and challenges we've had with the Latin American sites, just for this and future studies.
Yeah, so we are enrolling at Latin American sites for this. Thank you very much to Peru. I think they've enrolled 11 patients so far. And you know, we have it available in English and Spanish, so that works in both the US and in Latin America. We have had challenges related to two aspects. One is related to sample collection. Actually, they're perfectly capable of collecting samples and storing samples. That's not the issue. The problem is we can't get them to the United States. And so that is a challenge that is way above our pay grade. That it just trying to get them through customs apparently it can take a year. And so that's why we are saying that it's not mandatory. There are other sites, actually, countries where you're not allowed to do genetic analyses. So there's some country specific things as well. The other problem that we've had is we have text messaging, email, and also IVR as options for this. So if patients don't have a smartphone, we can still call them on a landline with the IVR. And I know in some other studies that Ethan Bosch and others have done, patients in rural areas definitely sometimes take advantage of that, or patients who are older, which is not our patient population. We have had a little bit of challenge, though, trying to do telephone numbers in other countries, just the way that, like, we can set up a telephone number, but then if here, and we can call them, but then if they miss the phone call and they need to call us back, it's an international call. And we don't feel that it's right to expect people to call us on international calls. And so as we still try to figure out those types of logistics, we are limiting the Latin American sites to email for the notifications for the weekly and monthly questions until we're able to solve this other issue. We thought it would be easy to just sort of have a phone number in country, and it wasn't that simple. So thank you very much. Thank you for supporting the study. If you do have questions, please reach out. And I realize I forgot to put the little contact slide in there. So the next one is just two quick updates on trials in development. So the first one, I don't know if she's on the call, is from Dr. Heather Greenlee, acupuncture to decrease symptom burden in patients with metastatic breast cancer.
Yep. Good morning, everybody. The S2415 trial is a trial that's testing 12 weeks of weekly acupuncture to improve overall symptom burden in both women and men with metastatic breast cancer who are on CDK4/6 inhibitors plus an endocrine therapy with moderate to severe symptom burden. This trial builds off the success of the S1200 trial, and we submitted this as a proposal as an R01 to NCI on October 5th. So we'll have information about funding hopefully by the late spring. I want to thank everybody on this committee for helping us get this through. I especially want to thank the PRO committee, Reha and Celine Jones, for all of the great work that they did in getting this out. And I also want to thank all of the 8 sites who submitted letters of support for this study. This will be a 15 site study. And one of the sites included one of the SWOG sites in Latin America, and this was the Chile site. And so we're planning to conduct this study in both English and Spanish. So fingers crossed for a good review.
Thank you very much. Fingers crossed indeed. So next, Jamie, let's talk about emerging from the haze.
Just a real quick update on our emerging from the haze cognitive rehabilitation study that's been in evolution for quite some time. It was developed by Dr. Arash Asher at Cedar-Sinai Medical Center and provides participants with a toolbox of strategies to help mitigate cancer-related cognitive impairment. So we just recently completed a 3-arm feasibility pilot that compared the real-time delivery of the intervention over 10 weeks to a pre-recorded facilitated intervention compared to waitlist control. And we did see significant improvement in both intervention arms on self-reported cognitive impairment compared to waitlist control. And we did not see significant between group differences between the intervention arms, which gave us nice evidence to support our next step, which is to take the pre-recorded version forward and pilot it in in-course sites. So we did submit a U34 planning grant, which was on the docket Wednesday at 11 o'clock. So I've been obsessively watching my email to see if we got reviewed and discussed. Stay tuned. I wanted to say thank you, though, to Cedars-Sinai, University of Kansas Minority and Underserved NCORE, University of Hawaii Minority and Underserved NCORE, Georgia NCORE, and Upstate Carolina. Those will be the 6 sites that will do the pilots at, should we be so fortunate to get the funding. Cross your fingers.
Very good. Thank you very much. And certainly, last but not least, I want to invite Dr. Amy Geschwender for a very important patient advocacy update. And while she's coming up to the mic, I just wanted to mention, because we've had a few questions online, you know, it seems like a lot of the trials that we've presented here are actually limited institution studies. That's not, we don't intend to do that. But what I do want to stress is both iCheckIt and Aspen are open to everyone. And so if your site is interested in opening those trials, please feel free to do so. And Amy will be up here momentarily.
Green button. Okay, so I hope you didn't mind my getting a little personal in the discussion about cognitive function after cancer. It's very personal to me, and I'm happy to help other people understand what the experience is really like. To look at me and listen to me speak, would you know that I have a bunch of very severe cognitive deficits that are clearly documented? Most people don't know. I compensate like gangbusters, but compensation is work, it's effort. It's another tab open in your brain all the time. So it grows to be a heavy load after a while. This sort of invisible disability is kind of tricky. You're not aware that people really need help, but they do. So I really appreciate that we're having a conversation about this. Because it is important. And like I said, you didn't know to look at me that I had to quit my job as a scientist because I have huge sustained attention difficulties, but I do. Doesn't mean that I don't have something to offer still. So you just had the green button for the slides? Yeah. Big green button. Okay, thank you. So as patient advocates, we have term limits. We're allowed to serve 2 5-year terms. So myself, Jack Aiello from the Myeloma Committee, and Tony Crispino from the Prostate GU Committee, we are all outgoing at the end of our term limits. And we have some new advocates to welcome. Trisha Hernandez to lymphoma. If you're here, please stand up or give a wave. Daryl Nakagawa for the Bladder GU Committee, and Karen Costello for Prostate GU. Ms. Costello will not be able to serve due to some personal family complications. So we do have an opening for an experienced advocate for the Prostate GU Committee. So please share that opportunity if you know qualified candidates who might be interested. I don't know if I missed it or what. So I have actually been granted an additional year as your advocate by Dr. Blanke because I missed about 1.5 years while I was in my own cancer treatment pretty recently. So I'm excited about that. So term limits are also affecting our leadership. Rick Bangs, our PAC chair, and Hildy Dillon, our outgoing PAC vice chair, are both leaving. And that leaves a bit of a hole. So We want to thank them for their service and also reflect on how Rick has been so instrumental in defining and expanding the role of the patient advocate throughout the NCTN cooperative groups. He's really gone to great lengths to make sure that all the groups consider patient advocates to be collaborative partners rather than mascots or checkboxes to participate in trial development from the very early stages. He also was the major contributor behind the Team Science 6-module series of training. And he helped to build this pack from like 3 or 4 people who informally gather to the largest, most active, and I think most well-regarded patient advocate committee in the NCTN. So SWOG is really setting an example to other patient advocate committees, and we're proud of that. We're excited for our new leadership coming in, Barbara Segura Vasquez and Anne-Marie Mercurio. Either of them in the room, they're probably familiar faces. They're both very experienced advocates. And we are excited to see where their vision for the Patient Advocate Committee takes us in the future. So they are, as of this week, taking on those new leadership roles. They will be co-chairs rather than chair and vice chair. We're all getting into this co-chair mode, right, with the new SWOG chair. You can expect in the coming months to see your patient advocates involved with implementation of the new DEI initiatives that SWOG is working on. And you'll be seeing us work towards what we hope will be more inclusive language to use in our trial development and trial materials. That's one of the initial things that the Patient Advocate Committee will be working toward, is promoting that inclusive language. We think it's important. Language is important from the very beginning because things you write in your capsule, they're like mushrooms in the backyard. They tend to kind of pop up all over the place. Those pieces of text live a long, long life. So we would like to care about that language from the beginning so that we don't have older language popping up all over the place, as is a common thing. So look forward to working on that. So want to thank the patient advocates who are completing their service. Thank you for supporting your patient advocates. And we look forward to hopefully your enthusiastic incitement about working in more inclusive language here in the work we do at SWOG. Rick Bangs, my first day here when I joined the committee, he sat me down and he said, "This is really important work, and I think you'll really love it." And he was right. It is really important work. And I'm excited. We're all excited to carry on what Rick has started and to keep this moving as an important thing that affects as many people as we are able to affect. And that is all I have. I didn't make a disclosure slide, but I do not receive any compensation for any of my advocate work. It's all on a volunteer basis. So, thank you.
Well, Amy, thank you so much for your service on the committee.
Hand me my little bottle of water there.
We're really pleased that you've been granted an extended stay with us, and we look forward to working with you in the role. You probably, weren't able to check the comments, from the meeting from the online participants, but your comments before really resonated with some people, and they have noted, for example, somebody said that they had a breast cancer patient who had the same experience with their employer as you had. So I think it's very moving, the comments that you made. Thank you for sharing that. And we can only imagine the lived experience of our patients, and we're trying to put together trials that address these issues, but these are still problems that we don't fully understand. We haven't had these issues, and we learn from you, and we learn from other advocates and our patients, and try to make a difference.
Yeah, these are big problems that affect every aspect of your life, how you relate to your kids, your dinner times, what you and your family can go out and do. There's something uniquely terrifying about the loss of the you inside your brain. I would give anything for my cancer to be a body part that we could lop off. That would be great. It's just so disturbing to realize that the you inside of your head is not the same you that it was before you went into surgery. So it's kind of a unique need. And I am happy to help people recognize, since it's not visible, I'm happy to help people recognize how much we do need help with getting on with our lives. Yes, I want to stay alive, but what am I living for? I have to be able to do the things I enjoy and take care of my family. And so that those goals need to be kept in mind, I think, at every step of the way to make sure that what we're saving people for is really worthwhile.
Well said. Thanks. Well, that completes our meeting. Thanks for joining us, everybody. Enjoy the rest of the meeting.